Today we're going to discuss about a very, very important topic of hypocalcemia, which is a very common presentation seen by pediatricians and pediatric endocrinologists. What we're going to focus is about cases which presented to a general pediatrician with typical features of hypocalcemia, but they turn out to have some diagnosis which was really life-altering. And just by making the right diagnosis, we were able to manage them appropriately. This was a case which I saw around 10 years ago. So this is one of the cases which really highlights how a person with a problem which can be diagnosed immediately has to go to multiple places, causing confusion. So at that time, he was 10-year-old. I saw him in one of my satellite clinics who had gone to a pediatrician with complaints of seizures. And they had found that there was an ionic hypocalcemia. Now, if you see, every finding would have given you a diagnosis. So what you're seeing here is that he had actually gone for a cataract and he had cataract. So hypocalcemia with cataract, first thing. Second thing, when I examined, there was a clear-cut calcification. So you can see a big calcification which is there in the leg. And this is like a calcinosis cutis was present there. When somebody had done a CT scan, they showed that there was a basal ganglia calcification. So hypocalcemia with cataract, with subcutaneous calcification, intracranial calcification, I think most of us will start thinking of a problem of an impaired PTH effect or pseudo hypoparathyroidism. And you can see a roundish facies, which is there. To make things even more clearer, he had brachymetacarpia as well. So if you wanted to have an exhibit of pseudo hypoparathyroidism in the form of hypocalcemia, with cataract, with cutaneous calcification, with skull calcification, and with brachymetacarpia, he was roaming around for so many years not to be diagnosed. So this is something which means that unless the brain knows, the eyes don't see it. This is the sort of a classical example of that presentation. And when we did the workup, he had a very high level of phosphorus, creatinine was normal, and he was found to have PHP. So many of these conditions are rare, but only if you identify would you pick it up. Otherwise, you will say it's rare, nothing is going to happen. Why should we work up? This was a classical case of PHP, missed across board, and we will see two more cases like this who had a problem. And then if you identify, you will have a good outcome which will happen in this perspective. Now, hypocalcemia, as I said, is common. Most of what the pediatricians will see will be vitamin D deficiency, some other causes, mild hypocalcemia, which will improve. But maybe 10% will have a permanent etiology. So my role today would be to focus on these 10%, how to identify, how to evaluate, and how to manage them appropriately, because this could be a life-threatening condition also in that situation. So all of you can go and have a look at our website, learning.growsociety.in, where we have got a lot of information, resources, and courses available of pediatric endocrinology, both for fellows, postgraduates, and other pediatricians as well. We've got the application, and we'll use some of those pathways regarding the diagnosis of many of these cases, and this can help you guide exactly which way to go forward in terms of evaluation and management. And of course, we've got the textbooks. So when we talk about circulating calcium, it is only 1% of the total amount of calcium which is there in the body. 99% of it is actually in the bone. And from the bone, only 1% of it is actually permissible and is going to be basically regulated with the blood. So 99% in the bone, out of which 99% is deeply rooted in the calcium hydroxyapatite crystals which are there. So this calcium will then go into the extracellular pool, and within that, 50% to 40 to 50% will be bound to albumin, plus there are other phosphorus and other forms in which it is bound. And then you have a free form, which is 50% is ionic calcium. And this is what we would worry about. So first message would be that if you have somebody who basically presents to you with total hypocalcemia, with no clinical features, please do a free calcium or ionic calcium, which will give you a real picture in that perspective. Now, under which conditions would you really be worried? Especially want to do a total, not a total, but a ionic calcium. Manoj, in which conditions will you do that?
Like nephrotic syndrome or alkalosis respiratory alkalosis.
Yes. So if you obviously have an albumin issue, then this albumin can essentially be there to bind it. If your albumin is less, your total calcium will be erroneously low. The second thing you talked about was alkalosis. Now, what we need to understand is that the amount of anionic albumin available in the blood depends upon the acid-base status. If you have acidosis, you will have more or less less anionic albumin. While if you have alkalosis, you will have high. So in conditions, if your pH is more or you have alkalosis, your anionic albumin will go up. What it would do is that it will trap your calcium. And therefore, alkalosis, be it respiratory, be it metabolic, can cause ionic hypocalcemia. And this is classically seen in somebody who has a renal failure, who has got acidosis and covert calcium deficiency. Now, what is happening there is that if you give them bicarbonate, immediately your pH will go up and your binding of calcium to the albumin will increase, and therefore you will develop hypocalcemia. So whenever you give bicarb injections in particular to CKD patients, always be wary of this tetany happening, because this may happen because of this anionic calcium. Second situation, if somebody is on ventilator and you are really having hyperventilation. Now, there are other harms of hyperventilation. From my perspective, this is going to reduce the ionic calcium. And that, of course, is something you want to do. Don't want to do it because there could be adverse effects because of that. So in this setting, if your pH is more, if there is alkalosis, there will be hypocalcemia, hyperventilation, soda bicarbonate, both conditions as discussed can cause this problem. Now, when we talk about calcium, we need to remember that there are three major organs and three major body systems which regulate, and the three major hormonal systems which regulate calcium. We have got the intestine, the bone, and the kidney. So how much you take, how much you excrete, and how much you basically exchange from the bone is what is going to determine your calcium status. Now, in chronic cases, the most important one will be the gut absorption. So the intestinal absorption will be what decides your chronic levels of calcium. While in acute cases, it has to be bone. Because kidney excretion is not huge. When you have more than 4 milligram per kg per day, you start talking it like that this is more likely to be hypercalciuria. So in that perspective, if you have increased excretion of calcium, that is not going to be a cause of hypocalcemia. Your major problem will be the intestine. So you're not getting enough from the intestine, or the bone is not exchanging normally, and this is what is going to be important from that perspective. There are three major hormones which regulate that. They include the PTH, which is basically responsible for affecting all three. So PTH has a direct effect on the kidney, causing greater absorption of calcium. It has a direct effect on the bone to get the calcium out of it. It is like your ATM card. Your calcium is low, PTH is there. Okay, you take out this much calcium. The third effect is indirect through the calcitriol production in the intestine. So the most important player across board in terms of calcium regulation is PTH. When you have high PTH, you will take calcium and phosphorus out of the bone. So what are the next thing you like to do?
So to increase the calcium, we would like to also have the phosphorus to be excreted.
Because suppose you get the calcium hydroxyapatite and you've got calcium and phosphorus, it is going to be bound together. Again, your actual ionic calcium will not increase. So the second thing PTH does is to shunt off the phosphorus. So anybody who has got hypocalcemia will have secondary hyperparathyroidism, will have hypophosphatemia. So low calcium, low phosphorus. If your phosphorus is high with hypocalcemia, either your kidneys are not working, or your PTH is not there, or your PTH is not working. Fourth would be if you have a phosphorus load, which is like an acute situation, tumor lysis, rhabdomyolysis, you will know that. So phosphorus is the most important investigation to look at in a child with hypocalcemia. Hyperphosphatemia would suggest renal failure followed by a PTH related cause. This is, I think, very, very simple to understand, because if you do not excrete this phosphorus from the urine, you will not have, your calcium levels will not increase in that situation. Now, this calcium has to be sensed somewhere. So you have, the body needs to sense that, and therefore you have a valent or dication sensing receptor, which is labeled as a calcium sensing receptor, but the same also senses magnesium. So it's like common between calcium and magnesium. And calcium and magnesium are cousins, and we'll discuss about that in detail as to how they influence each other in that perspective. Now, calcium binds to the calcium sensing receptor to really signal the body that, okay, calcium is high. If your calcium is high, you have to do three things. One, PTH should be shut down. I don't want any more PTH. Kidney should excrete this calcium. And third will be to shut down, to get calcitonin into the picture. So now the calcium is going up, come on and take this calcium to reduce in that perspective. Calcitriol is the second major player. It is the one which regulates long-term, basically calcium homeostasis. In the absence of calcitriol, only 25% of your entire calcium intake is absorbed, while if your calcitriol is sufficient, it becomes 40%. So this is a big thing. Suppose you are taking 500 milligrams of calcium. So in the absence of calcitriol, you're going to get around 100 or maybe 110 or something. But with that, it will go up to 200. So it may increase your net calcium absorption hugely. That is why vitamin D related causes will be an important cause of hypocalcemia, whether it is vitamin D deficiency, vitamin D dependent rickets type 1, type 2, they will all have hypocalcemia. What will happen to phosphorus, Naveen, in that setting?
So phosphorus will be low in case of vitamin D deficiency.
Why?
So because vitamin D is responsible for absorption of both calcium and phosphorus.
And what will happen to PTH if your calcitriol is less?
So calcitriol is vitamin, so it will increase, so it will also cause excretion of phosphorus.
So vitamin D, so grossly if you talk about from this perspective, there are two major causes of hypocalcemia, PTH related, vitamin D related. PTH related phosphorus is high, vitamin D related the phosphorus is low, which is quite easy to understand. The third player is calcitonin, which is a minor player. Now why I am saying it's a minor player, calcitonin comes from where? Naveen? From the parafollicular cells of parathyroid. If you have got hugely high calcitonin in medullary carcinoma thyroid, it will be thousands. You should have hypocalcemia, but no, it is not. So calcitonin is just a fringe player. It is just if you get too high, it will start working, but it is not a very good defense against hypercalcemia. So the main physiological regulator is PTH, followed by calcitriol, with a limited role of calcitonin in this whole picture. So now we discussed about the calcium sensing, and this is an important concept. So what happens is your calcium is sensed in different organs. So where should the calcium sensing receptor be? One, of course, is the PTH. So calcium should go to the parathyroid and say, okay, shut down the PTH production. So this will cause a decrease in terms of PTH production. The second would be it will go to the kidneys and will cause more calcium excretion. Third, it will go to the parafollicular cells and say, okay, calcitonin, get this calcium out. The calcium is becoming very high. So these are the various situations where calcium acts. Now, if you have a activating mutation of the calcium sensing receptor, what is going to happen, Naveen?
So there will be no PTH release, sir. So we'll have hypocalcemia with hypercalciuria, sir.
So this is a very interesting situation. If you have hypocalcemia, you should have hypocalciuria. Low calcium in the blood, low calcium in the urine. But if you have this funny trait in which you have got, basically you don't have any calcium, but body is thinking you have too much calcium. So basically your parathyroid gland is basically telling you that, okay, shut down. I don't want any more production. So that is low. And kidneys is excreting. So if you have hypocalcemia, you should have hypocalciuria. If there is low serum calcium, but high urinary calcium, it is calcium sensing receptor defect. So the second most important investigation, and I would say maybe third after phosphorus and magnesium, is urinary calcium, because that really helps you a lot in terms of evaluation. And we'll see in one of the cases which Sayan will present as to how it really made our diagnosis very easy when we looked at the urinary calcium in that perspective. So this is a rare disorder, but very interesting. Similarly, if there is a blocking antibody, if you have a blocking antibody, you will have hypercalcemia with hypocalciuria. If you have an activating calcium sensing receptor antibody, you will have hypocalcemia with hypercalciuria. So again, it can be congenital or acquired. In both situations, you can have this problem. Now, as I said, PTH is by far the most important regulator of calcium metabolism and its major site of action. Which is the most important site of PTH action?
PTH action will be to increase 1-alpha hydroxylase.
So the most important is at the level of the proximal tubule to produce 1-alpha hydroxylase to increase calcitriol. So what it tells us is that if you have hypoparathyroidism, all you have to do for treatment is, so ideally you should give PTH. See, if you have growth hormone deficiency, you give growth hormone. If you have testosterone deficiency, you give testosterone. Thyroid deficiency, you give thyroid. But what are you doing here? For PTH deficiency, you're not giving PTH because it is expensive, it is injectable, and a lot of issues. In rare cases, you will, which I'll discuss a bit later. But essentially what you're doing is that if you give a lot of calcitriol and a lot of calcium, you would take care of it. So the major effect of PTH in the whole system is through this calcitriol. But you need to also remember is that it also acts in the distal tubular absorption via TRPV5 to cause increased calcium conservation. So now what will happen in somebody who has hypoparathyroidism in terms of their urinary calcium excretion, Naveen?
Sir, it will increase.
So it will increase, but it does not increase because your calcium is low. So if you are not filtering anything, you will not have hypercalciuria. But when you start treatment, for any given level of calcium, they will get more urinary calcium than a normal individual. So let's put it this way. If a normal individual has a calcium of 10 and somebody who has hypoparathyroidism and a calcium of 10, the hypoparathyroid individual will have severe hypercalciuria because for them this 10 is not going to be retained. But when your calcium is 6 or 7, you will of course not be able to filter anything. This is a very, very major issue. So in hypoparathyroidism, you do not want calcium levels to go up in the normal range. You want 8.59, I'm happy with that. There should be no seizures, no tetany, nothing. I'm fine. I don't want to go above 9 because hypercalciuria and nephrocalcinosis can happen. Now, when we discuss about pseudo hypoparathyroidism, a very important point to remember is that pseudo hypoparathyroidism is a disorder which is interesting in terms of genetic terms. What is the basis of it?
Say imprinting disorder.
So when you say imprinting, what do you mean by imprinting?
Sir, imprinting, it depends on the expression from the parents. So in case if it is inherited from the mother, it will have some features, or in case if it is imprinted from the father, it will have different features.
Exactly. So when you say imprinting, it means that out of the 2 alleles which are there for that particular gene, only one is working. So maybe only the mother's is working, only the father's is working. So what happens with PHP is that for the calcitriol production, the mother's gene is working. So if the mother is affected, you will have this affected, and that's why you will have pseudo hypoparathyroidism. If it is coming from the father, doesn't matter. So father, the child will be normal. They may other phenotype which is pseudo hypoparathyroidism. But interestingly, the urinary calcium is a biallelic expression. So both father and mother is working. So if it is coming even from mother, your urinary calcium is not going to be a problem. So pseudo hypoparathyroidism will not develop hypercalciuria even if your calcium levels are high. So what does it mean? You can maintain calcium targets on the higher side with pseudo hypoparathyroidism. Now, why do you want to maintain calcium targets on the higher side? Sign in PHP. Because PTH is high. And if PTH is high in those areas where the GNAS1 gene expression is biallelic like bones, it will leach out the bones. So if you have secondary hyperparathyroidism, so to speak, or high PTH, you will have bone loss in pseudo hypoparathyroidism. So simply put, hypoparathyroidism maintain calcium 8.5 to 9, pseudo hypoparathyroidism maintain 9.5 to 10. Calcium sensing receptor, how much you want to do?
So calcium sensing receptor will be the least.
Even less, 8, I am happy, because as soon as it goes 8 and 8.5, they will have severe nephrocalcinosis which will develop. This is very, very important concept which we'll discuss later on in that perspective. The third effect, of course, is at the sodium phosphorus channel, where it causes the phosphorus loss and phosphaturia which happens in this situation. So PTH effect in the kidneys are 3: calcitriol, calcium absorption, phosphorus loss. And this calcitriol is then mediating the intestinal effect on that. Now, very important thing to remember is that magnesium and calcium. Now, magnesium and calcium are same. If you look at the periodic table, they are pretty similar. They are 2+, so cations with 2 ions. So they look very structurally similar. And that is why magnesium has a surreptitious effect on PTH. And this is very, very important to understand. Now, what happens is that magnesium binds to the calcium sensing receptor because it's the same. Calcium sensing receptor is the magnesium sensing receptor also. Now, magnesium binding to the calcium sensing receptor will cause what?
The same effect as that of
So
calcium.
it will cause something like hypocalcemia, hypoparathyroidism. So if your magnesium is very high, your PTH release will be low. Now, if you have deficiency, there is a bimodal presentation. If there is milder deficiency, it causes PTH resistance. Severe deficiency causes severe hypoparathyroidism. So, if you look at magnesium level, you can know what will happen to PTH in that setting. So, in the milder situation, you will have resistance. In severe cases, you will have again hypoparathyroidism. Now, there is a catch. Hypoparathyroidism also may cause hypomagnesemia. So you need to be really careful whether which is the chicken and which is the egg, which is coming first. So that we'll discuss in one of the cases which cause a lot of confusion in that regards. Now, what you need to remember here is that as the calcium levels are very low, your PTH will be very, very low. So severe hypomagnesemia, I'm talking about 0.4, 0.5, will have a severe hypoparathyroidism. As the levels increase, you will have a normal level, then you will have resistance, the PTH will go up, and once it goes up again, it will come down. So basically, there are trimodal effects of magnesium and calcium: severe deficiency, severe hypoparathyroidism; milder deficiency, resistance; excess, again deficiency, which will happen at the level of release. Now, PTH is going to act basically through the GNAS1 pathway. We are not going to talk much about that. But what you need to remember is that if you have chronic vitamin D deficiency, what will happen? What will body like to do? Because if the PTH is very high, it is going to eat up a lot of resources. So chronic vitamin D deficiency also induces a PTH resistance like picture. So if you are diagnosing somebody as pseudo hypoparathyroidism, always exclude vitamin D deficiency in that setting. Now, hypocalcemia should be suspected in a wide variety of presentations, including seizures, cardiac failure, intracranial calcification. Many times they will go to the neurologist and they will find that unexplained headache, so benign intracranial hypertension, stridor, cataract. So if you see that case, had seizures, had calcification, had cataract, but still was not picked up. So again, a close monitoring of these symptoms becomes important to identify. Now, if you look at the basic investigation, so if you have anybody who comes to you with suspected hypocalcemia, I would say do calcium, phosphorus, ALP, and maybe in the same sample, magnesium and creatinine, because these 5 will give you pretty much the most important things to look at. And what you need to remember is that there is always a postnatal dip which happens with calcium, and this is pronounced in preterm newborns. It is because of adaptations which happen, like glucose goes down, calcium also goes down. So you have to use age-specific references. When should the serum sample be taken for calcium sign?
So calcium can be taken at any time.
Yes, but if you talk about phosphorus, you want it in the fasting state, because if you have a carbohydrate meal, what will happen?
So it will increase.
Increase or decrease? So carbohydrate will cause what? Insulin release.
Yes.
Insulin will shift phosphorus inside, so you can have deficiency. So Ideally, because you're doing phosphorus, so it should be fasting serum sample. If there is hypoalbuminemia, the level will be low. If it's hyperproteinemia, it will be high. And there are various correction measures which are also available, which we can look at. So these are the reference ranges. Remember, they depend upon the birth weight and the gestational age subsequently. So different cutoffs are used. You can use this picture and look into the analysis from that perspective. Now, phosphorus, again, as I discussed, should ideally be done in the fasting state. Caution is that it is an intracellular ion. So don't squeeze it, don't use a tourniquet, otherwise your phosphorus will be falsely high. And in hemolysis, in rhabdomyolysis, so hemolyzed sample should again be avoided in this setting. And again, phosphorus levels are much higher in children because they are growing as compared to older individuals. So you use the age-specific cutoffs, and these will be relevant when we talk about our cases in that perspective. Now, from there, magnesium is also very important. In magnesium, there are so many units. A lot of people discuss that, okay, we get confused in the units, so we have made this table, millimole, milliequivalent, milligram. These three are there. Very commonly, the two ones are millimole. So if it is below 0.7 millimoles, or 1.2 milligram, you have to start worrying. But typically seizures will happen that will be like less than 0.7, less than 0.3 millimoles. So if you remember this table or just use it as a reference, you can understand what the magnesium levels are, and we'll be using that again later on in that perspective. Now, very important investigation is PTH. What is the most important thing you want to worry about when you're taking a PTH sample, Manoj?
We have to taking frozen.
So if you, it's a thermolabile sample, basically assay. If you allow it to keep in the room temperature, it will be low. So you have to always keep it in a ice. The second thing to remember is that you have to look it in context of calcium levels. So if your calcium levels are low, even a normal PTH will be low. If your calcium level is high, a normal PTH will be high. So in hypercalcemia, if your PTH is above 20, it is hyperparathyroidism. In hypocalcemia, if your PTH is below 60, I would definitely consider it to be inappropriately low. In that perspective, there is no absolute figure. Like for thyroid, we say that if your FT4 is low, TSH should at least be more than 20. Less than 20, we say central. Same concept will apply here. So if your calcium is low, PTH should be sky high. Often you will see 100, more than 100. This is typically pseudo hypo or secondary. If your PTH is low or normal, this is hypoparathyroidism. So always do a contextual assessment, and that becomes very important from that. So we'll run through a few quick cases to form the basis, and then we'll talk about those interesting cases from there. 4-month-old boy with nephrotic syndrome, calcium is 7.2, albumin is low. So do you think this child requires evaluation sign?
No, sir.
No. So you have to use a corrected one. And if you just use our app, all you have to do is put a calcium level and you put the albumin level, you will immediately get that this child actually has a normal level of total calcium and nothing to worry from that perspective. A 4-year-old girl with tetany, ionic calcium very low, phosphorus high. Now high phosphorus would mean what? Which three conditions? Manoj?
Renal condition.
Renal
or PTH.
and PTH problems. Okay. So PTH is 130. So what do you think now?
It is high.
So this is pseudo hypoparathyroidism. Okay, labeled as pseudo hypoparathyroidism. But you yourself said that the first thing to look at in this situation is a renal failure. So if we look at our algorithm, your calcium is low, phosphorus is high, no phosphorus load, obviously creatinine becomes important. So before you rush to PHP, which is very, very rare, think of renal failure, and this was the renal failure which is there. 10-year-old boy with seizures, ionic calcium is low, phosphorus is 4.4. What do you think, Naveen, in this case?
Sir, vitamin D deficiency.
So phosphorus is on the normal or the low side. PTH is not high. So could this be hypoparathyroidism?
Sir,
So PTH is normal
but
in hypocalcemia.
yes, sir, could be a
So
possibility.
very important is phosphorus, because phosphorus is not high. So hypoparathyroidism becomes less likely in this setting. No response to IV calcium, so you should do magnesium and vitamin D. Turn out to be hypomagnesemia. So phosphorus not high, do magnesium, and this will give you a picture in that perspective. And magnesium was very low in that setting. 3-month-old girl, ionic calcium 3.2, phosphorus 2.2. So what do you think? PTH is 3.4. Sign, what do you think here?
So the phosphorus is low, so not a primary PTH cause in this case. So most likely the vitamin D should be considered.
Yes, so probably as we were discussing, this PTH may actually be low because of a processing issue.